I really don't like saying that I do the McKenzie method or I use the McKenzie method. For starters, Robin McKenzie didn't name a concept or methodology after himself. It's called Mechanical Diagnosis and Therapy, or MDT, and at its core, it puts forward the idea of a diagnostic test called repeated movement testing. And this test helps us to find patients for whom the mechanical joint derangement is the diagnosis, and it can be resolved with one or two specific movements performed repeatedly. This diagnosis is, of course, not accepted in mainstream orthopedics or medicine in general, and therefore these patients that I find can fix their problem by moving in a specific direction repeatedly are given other diagnoses outside my office. For example, a patient with shoulder complaints whose MRI shows a labral tear may be diagnosed as a labral tear, whereas in my office, I may find that moving the neck in a specific direction repeatedly fixes all the shoulder complaints. Or the patient who's told they have IT band syndrome or patellofemoral pain syndrome. These are rather vague diagnoses that I don't find in my clinic. I find a specific root cause, maybe in the hip or the knee or the low back, that can be where the patient can move that affected joint in a specific direction and resolve the complaints. Nonetheless, the reason I don't like saying that I do the McKenzie method is because I don't want patients or people to think that's all I do. Robin McKenzie's work, of course, really impacts how I approach the human body and how I approach patients. But MDT does not teach me how to treat a patient post-surgically for an ACL or how to evaluate a patient who walks in with a suspected fracture. What is informed, or what does go through my mind when I see patients now, however, is that a potential diagnosis is a mechanical joint derangement. That is on my radar for all patients. So maybe a post-surgical patient walks in and progress is stalled. Well, then I may use McKenzie's repeated movement testing as a test to see if there is something deranged in the joint that will respond to a specific movement. When I think of patients, or when I think of providers saying they do Feldenkrais, I start to think that's all they do. And I don't want patients to think that using repeated movement testing or repeated movements as treatment is all I do. It is the bulk of what I do, but that's only because I find the bulk of patients have mechanical problems that can be solved with repeated movement. But for people who don't have joint derangements, for people who have structural problems like fractures or labral tears or dysfunction of the tissue that's actually tight, or other age-related problems, possibly like arthritis, their treatments are going to be matched to the appropriate diagnosis. They're not going to be necessarily moving in a repeated way in a specific direction. So yes, I use Robin McKenzie's principles, but I also use Lachman's principle when it comes to the knee. I also use other principles when it comes to stress fractures or structural deformities of the AC joint, things like that. Orthopedics is a large group of disorders. Many things can go wrong in the musculoskeletal system. I do, however, strongly argue that most problems that go wrong, especially when they're non-acute traumas, are mechanical problems that can be fixed, again, with specific movement. But Robin McKenzie and Stephen May's 5 textbooks on this topic really helped me to understand how to find those patients using repeated movement testing. But for the other patients that I'm seeing, we're not necessarily going down that path.